had little choice in the matter because I was told that the recorders, for want of a better term, were busy taking notes for the CDF meeting. So sorry about that late start, but we'll try to go through as quickly as possible. Apologies. Can we begin with a word of prayer? I'm going to ask Member Guy to, if he would be so gracious to bless us as we deliberate.
Good morning, everyone. Let us pray. Heavenly Father, bless us this day. Bless us as you have always blessed us. Bless this country. Bless the people of Jamaica. We hope that at this meeting this morning that you'll give us clarity of thought and that our decisions arising from this will be crowned with your glory and understanding. For all these and other mercies we ask in the name of your Son, Jesus Christ, our Lord. Amen.
Amen. Thank you very much, Member Guy. Any apologies for absence? Anybody? Any apologies?
I'm not certain, Chairman, whether Member Daly is with us.
Okay.
Has he?
I don't see him on well, I don't see him online, but he can state if he is. Is he here? No. Not yet anyway. No. Any other? Any other? No. All right. My welcome remarks will be brief. First of all, I want to recognize the presence of the permanent secretary, Mr. Dunstan Brand, who is online and present, and also our epidemiologist, Dr. Webster Carr, who is sitting in for the chief medical officer. She will give the update. And I know there was a special request for the PS to be here. Member Guy, you had requested the acting PS. He's actually not acting. He is the PS, confirmed.
Chairman, let's there be a misunderstanding.
Right.
All parliamentary committees need the accounting officer for the respective ministry to be at these meetings, and it's on that basis only.
Okay. No, I'm just clarifying. No, it's not a problem for him to be present. I was just clarifying that he's not acting, for the record. That's the best.
I mean, in his absence, I was saying an acting permanent secretary.
Okay.
But he's present, so thanks for having joined us today, PS.
Okay. All right. If there's no other matter, again, just welcome. Let me move right into the minutes. And
I'm sorry, I have one question of a general nature before we begin, Chairman.
Sure, go ahead.
Which is really relating to the presentations. I had asked at an earlier meeting for us to actually be saying the actual presentations. I know that the minutes capture a lot of what is presented and the discussion, but I think that when we have the actual presentation itself, it can be much more useful.
Okay, fair enough. I believe we had made a commitment to send them, so let's make a note of that. I'm going to ask the parliamentary recording secretary to make a note of that for me, please, so I can do a follow-up. Sorry about that. But you're correct. Most of what is said, or the substantive elements of it, would have been captured in the minutes. All right, so the minutes are before us. We'll move to page 1. Page 2.
I think I do have an issue on page 1. Let me just, it starts in that section with, I'm sorry, let me just get it. The matters arising. Let me just bring it back up. I made a little note here. Oh, right. So in that, at item 7, welcome, which is the
Item 7 would be page 2.
Oh, I'm on my phone, so I'm not sure what page that is. I thought it would have been page 1.
No, it's page 2. But
oh, okay.
Yeah. Okay.
Okay, so I could go ahead.
We're now on page 2.
Okay, thanks. So just 2 quick issues there. One has to do with that first paragraph, the last sentence in that first paragraph, which she suggested that agencies should put measures in place. I'd like it to be as sharp as I did last time around, which was that I suggested that government agencies should lead by example by putting measures in place to ensure that persons are practicing physical distancing.
So put government in front of agencies.
And make sure we also put that we're leading by example.
Lead by example. Okay, fair enough. I think that is clear enough and easy to.
And in the second paragraph,
Mhm.
The third paragraph, I think it was. Yeah, the third paragraph. Remember the dissatisfaction about the interpretation. It was an interpretation. I expressed dissatisfaction at the comments that were made regarding the opposition member's statement in the House. I think that there's a difference.
What's the injury there now?
Because I didn't say that it was someone's interpretation. I said because I really was dissatisfied with what was said. It could have been that it was someone else's interpretation, but I'm not saying that.
Oh, I see. Okay.
Interpretation or not, what was said, for me, I was dissatisfied with that.
All right, fair enough. Okay.
Good. And then further down, there's another one where it comes to, and the subject in the very end, just for clarity, she added that before that, she pointed out that suggestions have been made. That's okay. I'm coming. There is let me go back to that.
What paragraph are you?
Oh, she expressed that it's the same paragraph, just further down in that paragraph towards the end, about midway. 1, 2, 3, 4, 5, 6, 7, 8, 9, about 9 sentences before the end. She expressed. Oh, sorry, it's the second to last one. I'm very sorry. Second to last one. She added that the suggestions made by the opposition should be respected and accepted in the spirit that they were being given. I feel very strongly about it, so I want to make sure that the minutes capture it appropriately.
Okay, I believe she's noting that. All right, fair enough.
And that's it for me.
Thank you. All right, page 3. Page 4. Page 5. Pages 6.
Chairman, on page 6, in the
Yes.
final paragraph,
Huh?
the first line of the final paragraph, the verb should be pluralized, were, not was.
Easy correction. Thank you, member. Page.
Chairman, page 6 as well. I think I need a clarity here in the first paragraph. Referring to Dr. Bain, Professor Bain, he said that the persons who worked in laboratories were keeping abreast of literature and were sorting. He mentioned that some pharmaceutical representatives were also sorting and were not sending samples to government laboratory, which was risky. Is it that it was not or was sending or were sending?
Where exactly are you? Let me just look at it.
I'm at the top of page 6. First paragraph.
We're keeping abreast of literature and we're sorting. You mentioned that some pharmaceutical representatives were also sorting and were not sending samples to government laboratory, which was risky.
My understanding is that they were sorting their own products and were sending to the government laboratory, which was risky. But keeping abreast of literature. But could we have that a difference to the answer the writers to clarify this then, Chairman, if it's going to take?
I would prefer to do that. Yeah. Okay. So let's ask them to clarify that. Because I'm trying to recall what was said, and I don't want to second guess what he said. All right.
Chairman, just one point on the minute generally.
Yes.
Before we continue. There are a lot of square brackets in the text, which is unusual. And I don't know, I think the clerk needs to consult, perhaps with the senior clerk, as to how to address these issues, because they come across as draft minutes if they're filled with square brackets in the middle of sentences, and there are quite a lot of them.
Okay. All right. I'm going to make a note of that also.
Thank you.
All right. Page 7. Page 8.
When we get to any other business, Chairman, I'm not sure what page that would be.
All right. I'll let you know. Thanks. Page 9. Page 10. And I think that's where we are at any other business. But it's a few pages. So Member Brownberg, you wanted to comment on a specific item?
I did. The second paragraph, Chairman.
Okay, that one.
Member Bromberg indicated that public education messages from the ministry should be transitioned. Mm-hmm. What I did say is that it should transition in keeping with where we are in this moving to a new phase of transmission.
Okay, keeping with where we are in the phase of the virus you're talking.
Yeah, absolutely. And as you would see from below, I was actually referring to moving to community spread, and that we needed from then to begin to address what was happening in the communities.
Okay, got that.
I mean, in fact, in order to correct it, if you remove the full stop after transition and remove the next 3 words, she said that, and just make it one sentence, it would read, should be transitioned as the country moved to another phase of the COVID-19. It would make sense based on what. Yeah.
Okay, great. Page 11. And the final page, page 12. Okay, can we confirm the minutes? Any mover? Okay, Member Brownberg, seconded by?
I'll second it, Chairman.
Okay, Member Morris Guy. And matters arising. Now, let me just say before, in keeping with the efficiency that these meetings are known for, that our epidemiologist, Dr. Webster Carr, will make a presentation as outlined by the agenda on the overall status where we are and St. Catherine, and the concept of community transmission, which I know is an evolving theme, which I think it's important for the members to appreciate and understand. So if there are any issues around those, I think maybe best to wait until that presentation. Otherwise, matters arising.
I have 2 matters arising, Chair, unrelated to the broader point that that will be discussed in the substantive part of the meeting. First of all, the issue of the persons with disabilities being able to apply for the care under the care program, specifically the compassionate grant, and the difficulties that they were having because many do not have a TRN because they're not employed, and many cannot operate on their own and would need a caregiver to be able to receive the funds. You had indicated that you would raise this suggestion with the Minister of Finance. I don't know if you were able to.
Well,
it's at the top of page 9 of the minutes.
Right. No, I know. To be honest with you, not the way I should. Can I commit to raising it with him? We could informally discuss at Parliament today, and then we can make a note of it at the next meeting. Is that okay?
Yes, that's fine. Thank you.
Nudge me if it's not coming over to you today at the Parliament when we meet at 2 o'clock, please.
Yes, if I'm there. The other thing is the water situation in relation to how water is supplied, especially to inner city communities, where the NWC discontinues water supply without any notice. There's no scheduling. People can be without water for days at a time, as opposed to being told that these are the days on which water will be supplied so they can plan their affairs. This is a major problem, especially at a time when people should be washing hands regularly and so on.
Right. So I have had a discussion there. What I've been toying with the idea of probably inviting someone from NWC to spend a little time with us at one of these sessions.
Yeah.
Normally, there is some notification around scheduling of water, and normally the disruptions that are difficult to schedule would be the ones that are as a result of infrastructure maintenance, which are unexpected, so a broken pipe and so on. That's the general response from the NWC. I know that there has been conversations with the leadership around trying to ensure that we minimize those disruptions and that the notification around when water is available and when it will not be is sharper. But we could engage them in a more substantive discussion. But I have been a part of those conversations at another level, and I know they have been given instructions to be more vigilant, if you will, in terms of their programming, and that the citizens are aware, given what is happening with COVID-19. So I could try to I could ask them for a report if members think.
Yeah, I would really like to see exactly what they're saying about this matter, because I noticed that where I live, we don't get, if there are interruptions, we're made aware of them in advance and we can prepare. But in many inner city communities, they're routinely deprived of water supply with no notice, no information about when it will return, and so on, sometimes for long periods of time, many days. So to me, there's not equal treatment, and there is discrimination, and I think it needs to stop.
Okay, well, I'm not going to go that far to presume that that is the case, but I accept your suggestion that we may need a response from them. Member, you have your hand up, and then Member Brown.
There are two things that you indicated that you would have checked on, and arising out of the matter regarding the withholding of certain equipment for Jamaica and testing. You indicate that you checked to see whether ventilators were a part of this out of the USA from the last meeting. Could you care to give us an update whether they were part of what was withheld by the authorities?
We don't have an issue right now, as I understand it, as it relates to our supplies. As I said earlier, there were some delays in the initial stages. We're working very closely with the Ministry of Foreign Affairs and Foreign Trade, who in turn is working closely with the US authorities. And things are a lot smoother now than in the early stages. So,
whereas I understand that, Chairman, but could you say then if ventilators were part of that challenge we had with?
I'm not sure. I'm not sure how relevant that is now if things are moving very smoothly.
Chairman, I understand what you mean, and I understand where you don't want to go. But the reality is that this came out of the minutes, and you said that you would check.
I'm responding to you, member, with due respect. I'm saying that things are now normalized as a result of the intervention and coordination that is taking place between the Ministry of Foreign Affairs and Foreign Trade and the US Embassy. And I'm satisfied with what is happening. So we have no issues now in terms of getting supplies, including ventilators. And I think that is really what the country would be most concerned with.
Thank you.
Thank you. What about Member Brown-Burke? You have a comment?
Yes, I did. Yes, I did. Just very quickly to add my voice to Member Golding, because, and I understand why he gets to where he gets to in terms of the assumption around discrimination. The truth is that water is such an important issue now, especially in communities that are really densely populated and where we already have are placed at risk. So I think that is really an important thing for us to deal with. So I just wanted to add my voice there. But the question I really wanted to ask, I think when we were talking last time around, we were looking at some of the facilities that might pose a greater risk. And I was just wondering if we would be getting either any update, I'll wait for that, what we have been doing with infirmaries and nursing homes. Are we monitoring them? Has there been any visits? So we can understand and know that we are in fact being proactive.
Okay, so the infirmaries and nursing homes, as you know, well, the infirmaries, they're different. The infirmaries are the purview of the Ministry of Local Government and Community Development. Minister Mackenzie is a very important part of the COVID response, he and his ministry. He has presented a plan for infirmaries, and we are working together to provide support, we meaning public health, to give support to the infirmaries to minimize the risk. I mean, there's always a risk, but to minimize the risk. Part of that plan includes testing of the caregivers, having an isolation area for persons who may have symptoms so that until they are properly checked out, and there are some other measures that are being taken. But let me reassure you that it is a big part of the plan, given the vulnerability of that population. The nursing homes are the purview, certainly in terms of oversight and registration of the Ministry of Health and Wellness. And the agency that provides that oversight has provided a brief to the independent operators, and they are to comply with that brief. You know, it really now becomes an issue of how you monitor. And to be totally frank, there are many of those entities that are operating informally, which poses a risk because there is no monitoring per se of those entities. We have to make some special arrangements to see to what extent outside of the national coverage of the precautions that needs to be taken, that these entities, even in their informal state, provide appropriate levels of support. But it is part of the weakness of the system that we have quite a number of those entities that are informally operating, and that is a concern, member. There's no doubt about it. It is a concern.
Chairman, can I just suggest that if we could just from time to time get an update? I think when we look at what's happening across the world, in particular with nursing homes and senior centers, it is something that we have to be proactive about. And as you say, it is something that should concern us. So if from time to time we could get an update, just so that the nation is seized of what we're doing and what is happening, I think that would be helpful.
Okay, I'm going to ask the PS who is online to just make a note of that. I think it's important, and I agree with you. The member Madam Fort has her hand up.
Before you go to the AG, I had two.
No,
I said that.
Sorry?
I said I have two comments on the minutes, two matters arising.
Oh, okay. So you didn't raise the second one. Sorry, go ahead. Go ahead.
I was not allowed to.
Oh.
All right. I don't know whether I should ask it now or should I wait until we get the update in for St. Catherine. But the minutes on page 7 saw that there were 112 persons whose addresses could not be located, and I'd like to know if we had made some progress in respect of that.
All right, I think we have, and I'll allow member Webster Carr to, sorry, or invited member Webster Carr, epidemiologist, to comment on that in our update, if that's all right with you, member.
Yes, I'm good with that.
Thank you very much. Member Malahu Fort, you have your hand up.
Thank you, Chairman. I had raised my hand from page 1 of the minutes to say that I did ask for an apology for last meeting. Perhaps you had forgotten because of the meeting conflict, but I know the meeting has moved along since then.
Oh, okay. Well, we'll make a note of that. I believe I did mention that actually, but an apology.
Well, it said I didn't see an indication of an apology being tendered.
Okay. All right.
Thank you.
Thanks for that. All right. So can we move into the presentations now, if you don't mind? I see no other hand. Well, two hands are up, I'm going to ask you to take them down, Member Guy and Malawu, given that you have expressed your. Okay, thank you. All right, so I'm going to ask our epidemiologist, Dr. Webster Carr, to move quickly into the presentation, and then after which we'll engage further discussion. Dr. Webster Carr.
Okay. Thank you, Minister. Good morning, everybody. So the situation as of yesterday, we had 364 confirmed cases, of which 34 were imported, 8 were local transmission, and 94 were contacts of a confirmed case. Of that, 26 were import related, 23 were related to the persons who were considered local transmission, and we did not find any epidemiological link, and 45 were related to the workplace cluster. 182 of the local transmission were related to a workplace cluster. So we had an additional 182 as a local transmission. 46 persons are currently under investigation. To date, we have tested 3,621 samples, of which 364 were positive, and we still have 26 pending. 3,231 were negative. Over the last 24 hours, that is up to 3 p.m. yesterday, we performed 377 tests for that 24-hour period. We have 320 persons in isolation. Of that, 98 are in hospital, with 2 critically ill and 6 moderately ill. 7 persons have died and 29 have recovered. There are 91 persons in quarantine. The pie chart shows where we have the persons in isolation. Most of them are in non-hospital facilities, then followed by hospital 98, and step-down facility 24, and at home 72, based on their assessment.
I'm sorry, was that the pie chart? Are we sharing, is there something to be shared so we could see the pie chart? Or that's just a notion?
You're not seeing, oh.
It's up on the screen.
You're not seeing the screen?
Seeing the screen, the presentation?
No.
Anybody seeing the screen?
Let me share again.
Is anyone else seeing, anybody at all seeing the presentation?
I've only seen you and the epidemiologist, Minister.
Oh, sorry.
Oh, sorry, because we're presenting a PowerPoint presentation.
Thanks.
I'm sorry about that.
Sorry. Okay.
Start over.
I'm seeing the screen.
Okay, good.
Yes.
You're seeing
It's
it?
now up. It's up now.
Yes, I'm seeing the screen.
Oh, okay. You want to go back to the front, the
Yeah.
other slides? Sorry about that, members. We thought you guys had it up.
Okay.
Not moving.
All right. I'm not getting to move it
Can it go the other direction?
from, let's see if that works.
Need somebody from IT.
It should share.
It is sharing, Dr. Webster Carr. It is sharing. We're seeing it. But
So, it's not. It's what I'll do is close.
No, what you need to do is just click on the individual slides as you go through. If you click on the slides, it will come up.
Okay.
So you can't publish you can't do the PowerPoint publish, but if you click on the slide that you want to touch on.
Okay, we'll try. We'll do that. I'll get this as large as we can. Oh no.
No, the size that it is at is fine.
It's fine. Okay.
Yeah. Mm-hmm.
Okay. So this is the pie chart that I was referring to as to where persons are isolated. Most are at non-hospital facilities, followed by hospital, then home, and then the step-down facilities. We go on to the distribution. Okay.
Still not moving?
I'm clicking. There seems to be some delay in the advancing of the slide.
That's a long delay though.
Yes.
No, we're seeing the distribution by time.
Oh, you're
Yes.
seeing it. Oh,
Yeah,
okay.
we're seeing
Yeah.
the distribution by time.
Okay.
Yes, I'm seeing.
Okay, because what we have on our screen is a little different. Okay, so that's good. So we have on the left-hand side the total cases, the cumulative cases by time, and Jamaica overall there was an increase because of the workplace cluster. Because if the dotted line, if we didn't have the workplace cluster, then that's the trajectory that we would have been on. So we moved from an 8-day to 9-day doubling to a 5-day doubling when we had the introduction of that workplace cluster. The number of cases, the clustering of cases by time as shown by this chart, and we will show you the workplace cluster, but majority of persons initially, as you would see where there's a little plane, that many of the persons came in and we had imported and import-related clusters. Currently, the epidemiology has changed and many of them are related to transmission, whether it's the cluster or new cases that are coming up from the community. And so this is the workplace cluster outlook.
You know, I'd love to be able to see it. That's a challenge here now.
Okay.
Okay, go ahead.
And any comments on the workplace cluster, Dr. Webster?
So we will go into more details about the workplace cluster, where there are parishes, age, sex. We'll do that in a little bit. Okay. So this is the geographic spread. Showing the different clusters of cases and how they are connected geographically. When we look at the age distribution, the overall, the majority of cases are in the 20 to 29 age group, and this is heavily skewed by the workplace, where most of 123 of the 82 are from the workplace cluster. So the age distribution overall range from 2 months to 87 with a mean of 32. When we exclude the workplace cluster, I think there's a mistake here with the mean age. The mean age should be 43. So I need to correct that error. So the mean age here will be 43. The workplace cluster, the mean age is 28. When we look at sex distribution, overall we have more females than males, which is different from what is seen globally. But when we take out the workplace cluster, you have more males than females, 55 to 45, because the workplace cluster has more females, 60% females. Oh, this is, the colors are wrong, 60% females and 66% female and 34% male. This was twisted a little bit. So I apologize for that. When we look at geography, by parish, overall 57% of persons are from St. Catherine overall. But if we look at St. Catherine alone, there are about 75% are related to the workplace cluster. 153 of the 208 persons are related to the workplace cluster. So the workplace cluster is affecting the outlook of St. Catherine. So if we—
You could say the outlook of Jamaica too, couldn't you?
Yes, outlook of Jamaica.
In that it's well over 50% that's linked to the cluster.
Right, so—
The overall, in terms of the overall numbers.
Correct. So about 60% of the cases are from St. Catherine for Jamaica. And so I agree with Minister that for the country, the workplace cluster is affecting the outlook.
Would you say, when you say they're from St. Catherine, do you mean they live in St. Catherine?
Right, correct. They reside in St. Catherine.
Okay.
Sorry, question, Dr. Weftakar.
Yeah.
On the particular chart, you said that of the 153 of the 208 in St. Catherine are from the workplace cluster.
Yes.
Now, have you included in this workplace cluster contacts for those persons, or this is just for the workplace per se?
This is just for the workers. So the 182 is just for the workers. If we include the
Contacts will take it over 200.
Yeah, the contacts will take it over 200. I was trying to look for so it would carry to 274. We'll carry to 274 if we included them.
Are you sure? 274?
Am I? No, sorry,
not
not 274.
That's the overall.
That's the overall. I will have to do that. So we have the 182
I think it's about 30 odd. So
plus 45. 132 plus 45. 132 plus 45.
No, 170 something plus 45.
182. You remember from yes, it increased with the 16.
Yeah.
Yeah. So that is 227.
247. You have 182 from the workplace cluster plus 45, is it?
Yes, plus 45. 182 plus 45.
227.
227. 227.
Okay, continue.
Okay, so this is the geographic distribution by community. And this is where we were 14 days prior. So as of the 27th, this is where we are. And 2 weeks prior, this is where we were on the 12th of the 13th of April. This is the workplace cluster. So the dots represents the actual confirmed cases, and the shaded area were the residents given by the workers. So the workplace cluster is distributed mainly over 3 parishes. Firstly, St. Catherine, followed by Kingston and St. Andrew, and Clarendon. There were other cases in Portland and in St. Thomas. Just to, for many of the symptomatic cases, fever and cough were the most common, and the others followed. Sore throat, abnormal breathing, and shortness of breath.
Do we know what percentage of the positives, the 282 plus the 45, the 182, the 227, what percentage of them, of the workplace cluster, were asymptomatic or are asymptomatic?
Close to 80%.
Almost,
I believe.
yeah, almost 80% are asymptomatic.
It's a comment I want to make, but probably we'll wait until after she completes.
Yeah, okay.
So when we look at the surveillance of respiratory infection, this is what would indicate the level of possible community spread. And what we have noted over time is that there's a general increase in the number of cases from this surveillance method. So these are persons who really wouldn't fit a case definition, but have influenza-like illness, or they have a pneumonia, or they have some respiratory symptoms, not necessarily respiratory and fever, and they were tested. And this is what we have for the first, up to week 16. We are gathering the data for week 17, which completed on Saturday, which is showing at this time an increase over week 16.
What does EW stand for?
Sorry, epidemiological week.
Okay.
And the areas that we have noted are Portland, the hills of Manchester going into Trelawney, St. Catherine, and Clarendon.
So just to be clear, those were positive cases that your surveillance has picked up?
Correct. So these are sporadic cases.
Because they presented with some kind of respiratory problem, and they turned out to be positive. Okay, all right.
Correct.
Remember, members, again, I don't want to delay the presentation because I think you'll get the full understanding after it's done. But we do have these Centennial sites that picks up, that automatically tests anyone who comes into the public health system with an upper respiratory illness, influenza-like symptoms. So, and that is the kind of control group that gives us an indication of community transmission, because they have no known tracing that has taken place, no known travel history or links to a positive. It's out of that case scenario that you start to do community tracing rather than community tracing that leads you to them. So the more you see that happening is the more you would conclude that there is community transmission taking place. All right, go ahead.
Minister, like for example, just following on that quick point, like EW16, there were 7 positives found through that methodology, right? In EW16. What would that 7 represent of the total number of persons who were tested in using that method, that sort of respiratory surveillance method? 7 out of how many were tested?
So we estimated about 45 persons were tested similarly for that week.
Approximately 45.
Of which 7 were positive. Okay, thank you.
All right.
Okay, go ahead.
Minister, no. I have a little challenge with that last question that member Golding asked. Are you saying that our Sentinel sites have only done 45 samples for the entire country for the epidemiological week of 16?
So what we do, Dr. Guy, is that we have to look at all the cases. Some may have been linked to, when we look at overall that week, we had to link back some to contacts. So there may have been more that were tested that we are looking at now. Because based on how many were tested that week, because priority was given to the other contacts, etc., for testing that week. Now that the testing has improved, the numbers will increase. So based on what came in on the report, there were more persons that samples were sent on for, but we are only about 45 were actually respiratory symptoms.
No, I don't think my question has been answered properly.
Okay.
I'm just asking a simple question. Of all the sentinel sites you have now, which are all the hospitals, selected health centers, and as was indicated in the previous minute, some private medical facilities, are you saying that there are only 45 samples that came for that particular week to the Ministry of Health? That's a simple question I'm asking.
And the answer is no.
So, member, just to...
How many of them that came in then?
So I'm just having a look based on what we have here. I'm looking at the Sentinel report for severe acute respiratory infection. We would have about 30. Based on the other reports, I don't have the exact number here. I'm hovering over. But influenza-like illness for the
Minister, Chairman, can I ask that we get the particular information so that we are correct with our information? So if we could just provide that information.
I think that's a wise suggestion.
And we can get it before the meeting is completed?
Well, I can't promise you that, member, because one, we have to follow up, but we certainly will get it, and in the shortest possible time. So can I just ask her to continue, and then when PS, you can probably send a WhatsApp via your mobile device and ask the relevant person if they can get that information. I have no issues with that at all. Is that okay, member? So we can just proceed?
Okay, Chairman, but I'm sure we could get it before the meeting is completed, but we'll work with that for now.
Appreciate your understanding, patience, and accommodation. Member, could you just, sorry, Dr. Webster, could you proceed?
Yes, so the WHO transmission rates define community transmission as countries, areas experiencing large outbreaks of local transmission defined through an assessment of factors including but not limited to large number of cases not linkable to transmission chains, large number of cases from sentinel lab surveillance, and multiple unrelated clusters in several areas of the country, territory, and area. So,
do we meet that criteria?
So we meet some of it. What is there that it is the large numbers. We sent an abstract to PAHO WHO, and right now they have us as cluster of cases. But large numbers is what we have a difficulty with. What is large number for our population?
Yeah, but if you have health sites, which is just a general population who have respiratory problems and then they're tested, it's only 7 you're seeing across Jamaica is 7 cases in a week. That's not a very significant number.
I don't think you can do absolute though, member. You have to do as a percentage of overall numbers present turned up within the system. I think we have to gauge it like that.
Yeah, well, we asked what that was, and we haven't been told yet. But you know,
right. So that's why I think we should hold until we get that information. All right. Go ahead.
Right. So inferences, the number of COVID-19 cases of unrelated clusters are increasing. Cases that have been identified in all parishes except Hanover. The cases identified through respiratory surveillance has shown a general increase in since epidemiological week 11, and community transmission, we are saying is imminent or could be present, because what we see 1 week is related to what happened 2 weeks prior, the transmission that occurred 2 weeks prior. And case investigation and contact tracing, while labor intensive, is essential for Jamaica's situation in identifying the COVID-19 cases, because of all the methods, 75% of the cases are through contact tracing. And so this is essential for our assessment of where we are for containment. And so in essence, that is the presentation. However, with regards to St. Catherine, there has been 1,513 persons from the workplace clusters that have been interviewed and sampled, 685 of which were workers, and we have outstanding approximately 50 workers. So that is down from the 100 and over 100 that were last week. And we have done 28 contacts of workers.
So just to be clear, the question that was asked earlier about the 112 unaccounted for, that's down now to 50, you say?
Yes.
So we would have made some progress and still working on that.
Correct. And so from St. Catherine, we have isolated or quarantined 204 persons, including confirmed cases and contacts. So 7 are in hospital, 145 are in government facility, and 52 are at home, where the home assessment was good and could be quarantined or isolated at home.
What type of government facilities are used for this? What type of government facilities are used for this, for isolation?
For
persons who are not in hospital.
For quarantine.
We have 3 facilities. The PS can comment a little more on it, but we have 3 facilities that we have engaged that have the amenities, the room, own bathroom, the amenities to quarantine and or isolate. And it is in those facilities that we have placed those individuals with appropriate levels of clinical supervision.
Yeah, I'm not asking for the specific identities, but what type of facilities are? Is it a hotel? What is it?
Yes, it's a hotel. They are hotels, not one.
Yeah. All right.
Yeah. Okay. Go ahead.
That's it.
Okay. I know we've had some stops and starts in the presentation, and I'm sure members have their questions and comments. My own points would be that the issue of asymptomatic versus symptomatic, and the isolation versus and quarantine facilities as opposed to hospitals. What is happening as it relates to the workplace cluster in St. Catherine? Clearly, St. Catherine as a parish is ground zero now in terms of the numbers, the concentration of cases, which places citizens in that parish at a greater risk for contamination or spread, given the numbers that have emerged from there, linked primarily to that workplace cluster. We still have some work to do there, which is why the Prime Minister announced a continuation for a few additional days on the partial shutdown, if you will, because we have the 50 or so persons to contact. It's a moving target because it changes, because the team is in the field. But we also have an additional 250, I think, Dr. Websakar, that was what we said yesterday, of their contacts. So for the 50, we have another 250s of their close contacts that the team on the ground are working on. That involves the contact tracing, the interviews, the assessment of their home environment to determine whether or not they can be quarantined and isolated in those facilities. We have isolated some persons in their facilities, I think just over 50, because they have appropriate facilities. Others we have moved out. So that exercise is taking place, and the team felt that they needed a few more days to deal with that, given the fact that if we don't, it could mean greater spread or greater risk to that population. The other issue that I think is worth noting is the issue around asymptomatic versus symptomatic. A very large percent, there is a profile associated with this workplace cluster that is young, you are youthful, and generally asymptomatic in terms of their presentation, which allows them not to be in a hospital setting and still get the care that is required as long as they are quarantined or isolated. And so what we are doing is to provide that kind of support. And it is important to highlight, because the short history of the virus and the approach to treatment is going to require more home care than hospital care. And so we need to sensitize and get the public to understand that that will become the norm over time as the virus spreads. And this cluster has provided an opportunity for us to zero in on that, which is what is taking place.
Minister,
right.
could I just ask you one question on that though?
Sure.
They're asymptomatic, which means they're not sick. They're just tested positive, right?
Yes.
So they don't really need medical care as such. They're just being quarantined so they don't spread it to anybody and so on. But it's really to prevent further contagion. But they're not ill, these people, these asymptomatic people, not sick.
Right.
Is that right?
Right. Okay. I see Member Guy and then Member Brownberg. Member Guy?
Thank you, Chairman. Just a quick question, or a couple of questions that I have. The matter of the cluster in St. Catherine, can I get some clarity on which persons are of that workplace cluster or that workplace entity? Which persons are in government quarantine or facility? I ask it against the background that persons who work have complained that they have been quarantined, self-quarantined at home for at least 10, 11 days. And now they're almost going to the 14th day, have been told that they have tested negative, but yet they have been moved to one of the facilities in St. Anne. What's the rationale for that?
Okay. Again, the clinicians are here. I understand that Dr. Simone Spence is online, so either of them can come in. But my understanding is that the issue of whether or not to house is a function of the assessment of the risk. If that individual, in the eyes of the clinicians on the ground, doing the contact tracing, doing the assessment, is assessed to have had a greater level of exposure, and therefore the virus could be there but not presenting itself, then that person would be placed in and their facility is not sufficient for them to quarantine in their facility. Then they'll be placed in that facility until there is enough time to evolve to demonstrate that the virus is truly not present. So it really is a function of the risk assessment, member. And that we leave to the public health officials on the ground who would have interviewed them, looked at their environment, looked at who they have been in touch with or came in contact with, where they were, where exactly in the building they worked to a positive case, that sort of thing. And I don't want to second guess them, so I think that's a reasonable assessment.
But Minister, if you don't want to second guess them and you say you have one clinician here and another joint, could we get an from their perspective? I mean, I'm not doubting what you said, but I think it's critical that we do.
I'm a non-doctor, yes, that's true. I may be a bit forward in offering that explanation.
About that another place, you know.
Member Webster Carr, can you?
So it was dependent on the assessment done. The risk related to, because some of them, their home facility may have been good, but when they were checked, they were not at home, or when they're called, they're elsewhere. So based on their behavior, their home assessment, defining their risk, then they were moved based on that. So there were a few persons who were negative who were moved because of the risk that they posed to further spread should they become positive in the incubation period. The majority, however, were positives who were asymptomatic that were moved to facility.
Thank you.
Okay,
Any other
thank you.
questions, Member Guy?
Not yet. I have some general questions, but I'll wait until after, Chairman.
Okay, oh, sure. Member Brownberg, your questions?
Sure. So if I just follow up with the individuals who have been moved, I've gotten a few complaints, not many, but I would want to ask whether or not persons, the individuals who are actually being moved, if they fully understand why they're moved and the basis of it, because there seems to be some doubt in terms of exactly why. And persons that's what they're asking, why was I moved? So I want to ask for us to check on that and just to ensure that we have informed citizens that we are dealing with, because I think it's going to be very, very important. So that's one. A notice came out, I think it might have been from the ministry, to individuals, particularly St. Catherine. And one of the sentences that kind of had me a little confused was the instruction for individuals to remain at home, which we understand that, until contacted by the ministry, even if the 14 days have expired. Why it concerned me is that I know we have just said that we have about 50 maybe workers that we are not accounting for. But it would have sounded to me that the message was for individuals that we are accounting for because they are either in isolation or self-quarantine or whatever. And I didn't understand why the message would have been framed in that way. Because I would have expected that every single one of them would have had at least a contact from the ministry by now.
Okay, sorry, Dr.
Okay.
Webster Carr, you want to answer? Dr. Spence, you're online. You want to try that? You have better particulars on that?
Good morning, everyone. Yes, Minister. Is everyone hearing me clearly?
Very well, go ahead.
Okay, so Member Burke, in terms of that particular question, it had come to our attention because as you are aware, the St. Catherine Health Department team is charged with monitoring these persons. And it seemed as if, based on information they would have received, that persons were, even though already contacted, would have been spoken to, would have been contacted on a daily basis to make sure that they are compliant. Some were getting quite restive as they're approaching the end of the quarantine period. And so we just wanted to reinforce the message that until they would have been contacted via getting their official quarantine relief at the end of their period, that kind of thing. We didn't want to go into too much detail to confuse persons because it's varying different stages that people would have been at. We just generically just said that wait until you had been contacted by the health department.
Okay, understood. My final question. Minister, we keep saying that, well, the government keeps saying that more and more we are going to be seeing more home care versus hospital care. And that, in fact, I think the word used is that is going to become more the norm. I'm a little concerned about it being said in such very broad terms. I understand the profile of the individuals that we are seeing now, many of them who are young, many of them who are asymptomatic, and many of them with mild cases. But I am concerned that as we move from this phase, and we probably have more individuals who show up positive, that may not be the profile. And in fact, a number of individuals who are individuals at risk have been asking me what that means for them. Because as you would imagine, psychologically it's taking a toll, especially on individuals who have underlying conditions and who are worried that this idea of a home care versus hospital care would mean that they have their underlying conditions, they are positive, and they're going to be told to stay at home.
Right. So
yeah. And so I wanted some clarity around that.
So I appreciate that, member, and I will take a first at it, and then I'll allow the clinicians to come in. If you recall, the first presentation that was made to this committee outlined the modeling that was done that suggested the numbers that would likely be affected or infected over a 12-month period, which was in the region of 1.5 million or thereabouts. The modeling also, based on the history and sort of linked to the 2008 H1N1 virus and its spread and impact, also quantified in broad terms the numbers that would likely, having been affected, visit the public health system. I think that was 400,000. And the numbers that would be sufficiently ill to require hospital care, I believe that was 2,000 or thereabouts. And the numbers that would be so significantly ill that they would require intensive care or high dependency care. And I think that came up to about 350, 400. And those would be the persons who have comorbidities, advanced age, immune system compromise, that sort of thing. And then even a smaller percentage of those would require ventilation and so on, ventilators. So if you take that modeling over that 12-month period, then it logically, you would conclude that the majority of persons who have the virus would not be sufficiently ill or symptomatic to require hospital care. I will accept, you're very right, that the fear around the virus in the population does generate additional anxieties when you hear you don't need hospital, because people think the virus is so detrimental. And in some instances, maybe more detrimental than it really is. Fear is always greater than the actual event in most cases, which is one of the reasons why we need to talk about it. And I think this is a good place to do so, which is why I put on the agenda here the issue of community transmission. Because as you get to that phase, which we have always said we will get to, people are going to have the virus that are not sufficiently ill to require hospital care. And what we have to do is to condition the minds of the population to accept and recognize that, and not to suggest that if they need care, they won't get care at the hospital, but just to say that if you don't need it, then their alternative is to be at home, to quarantine or isolate, and to take normal treatment and get over the virus. So it really is an effort at public education to get the public to conform to what is likely to play out in terms of the strategy. Dr. Spence, you want to come in on that? Am I off key in any way?
No, sir, you're not off key. Just to add in support of what you're saying, is that it really is balancing, and there's a lot of things that go into assessing the persons that require hospitalization based on the severity of what it is they're suffering in terms of signs and symptoms. But because the vast majority of persons who will be impacted by this disease will actually have no symptoms or mild disease, when it comes to that point, then they can isolate at home once their home circumstances are appropriate, and they follow the instructions that are being highlighted.
I may add to that there may be cases where home situations are not, and there will be need for some institutionalization, but not necessarily hospital institutionalization. And that's part of the plan that we have to concretize as we move into this phase and as we adjust the modeling to restore normality or the opening up of activities, including our borders. So that's something we will come to in another week or so, when we will have a discussion around the concept of global.
Miss, I just want to suggest that and I understand that what has been said, I mean, I understood it from that perspective as well. But because I've been getting so many calls from individuals who are at risk in terms of just the kind of almost, they use callous. I'm trying to find a nicer word. How we just transition from saying, oh, you know, most people are okay. It's only those with the comorbidities are going to die. Just that we remember that we're talking about human beings and we're talking about lives. And so when we try to explain, and I know it is a delicate dance, I want us to make sure that we see the people in front of us that we're talking to.
Appreciate that intervention, but just to be clear for the record, we're not at all trying to devalue the importance of the prevention methods and the curative methods that we'll need. This is not suggesting at all that those who need hospital care won't get it. We are preparing our hospital system for providing that care. COVID wards are being set up right across the country. I looked at 3 hospitals this weekend, Mandeville, Black River, and Sablamar, and they all had wards. Most of the beds were empty, but that's in preparation and anticipation of. So the public should not fear that part of the strategy. However, I think it's important for the public to also recognize that COVID-19 is likely to be around for a very long time, and we have to manage the process in a way that gives a response that is warranted based on the circumstances and situation. So I appreciate that, and if we need to help the public in that regard. Member Golding, I see your hand up.
Yes, thank you, Minister. I have a couple of questions. First of all, as regards the workplace cluster, is it the case that all of the persons who are at the Alarica facility, whether as employees or ancillary, whatever they were, if they are, as they are located, that they are all tested? That's the first question. Secondly, that their contacts, their close contacts, once identified and found, are also tested. I just wanted that to be clear, whether or not that's the case. And secondly, in relation to that, if they are found to be positive, but they're asymptomatic, what is the protocol for their release or from quarantine over time? Is it because I know, for example, in the hospital situation where someone's been sick, there is a process where they're no longer showing symptoms, and you have these 2 negative tests that have to be achieved before they're treated as fully recovered. In the case of an asymptomatic person who is positive but is not in a hospital, is either in a hotel arranged by the state or possibly at home, what is the protocol for that person being told they are no longer a risk to anyone else and they can move around? That's the first batch of questions I want to ask around the workplace cluster. There are a couple other questions I want to ask as well, but if you could just have those answered, I'd be grateful.
Okay, you want to take that
first?
first
Okay, so workplace cluster, we had, for St. Catherine alone, we had 685 workers who have been tested. St. Clarendon had 12, and KC had about 50 who were not tested at in St. Catherine, because St. Catherine tested some of the KC persons. So the numbers are for the workers. So far, we have done approximately 1,000 between KSA, Clarendon, and St. Catherine.
So the policy is for all of the persons who are at that facility as a worker to be tested. That's the policy.
Correct.
Yes, and I think we have done most, if not all.
Most if not all. So that's approximately 50 persons that we are still looking for.
Right. And similarly, the close contacts of all of those persons are to be tested as well.
Right. And these are some of the positives that we have mentioned, the 45 who have been positive already. So we are closing the gap very quickly on that group. The matter of the protocol for release is the same. They would have to achieve at least 2 negative smear.
Okay, thank you.
Same protocol, member, same protocol.
Thank you. Now, with the workplace cluster and being roughly 80% asymptomatic, is that also the case for the non-workplace cases that we have had, the positives that are not related to the Alarica facility? Are 80% of those positives asymptomatic, or is it a different percentage?
It's a different percentage. I don't have it right now, but it's probably about 25%.
Significant. So that's a very significant difference.
Yes, it is.
Bear in mind, member, that the workplace cluster is a very, should I say, it's a
young and fit and healthy group.
It's a subset of the population that is deliberately chosen for the reasons that are targeted to that particular industry. And the profile, of course, is young and energetic and active and all of those other things. So it's almost like taking out the strongest subset of the population, but putting them in a confined space where they become exposed, and for the very reason that they are chosen for the productivity levels that industry requires.
Yeah, but I still think it's remarkable. I still think it's remarkable that 80% of that subset are asymptomatic, whereas amongst the remaining positive population that we have tested, it's more like 25%. I think that's a very significant difference. And I accept the explanation. I'm just saying it is a very significant difference.
I would only say that it's not necessarily remarkable given the experiences of other jurisdictions, in that the people who tend to be hospitalized, unless those young persons have underlying conditions, it really tends to be at that other population and with those other issues. But anyway, go on to your next question. Sorry.
Yeah, I mean, I guess it goes to the extent of testing outside of that workplace cluster then. If, in other words, if you're saying that it's really persons who are hospitalized who, who would exhibit symptoms, then clearly that's so. But I'm interested. The other question I had was on the persons at the facilities that are being tested because they have respiratory illness. The weekly data that you have presented, the most recent week, showing 7 persons being positive, and we asked for the specific numbers of who had actually been tested out of that category, and you are going to try and provide that number for us. But the point, going back to that point though, what are we saying then, that in the whole of Jamaica, really, for persons who have presented with a respiratory problem, we've had 7 in that week, 7 of them tested positive for COVID. Is that what we're really saying?
Yes, but we have to look at the methodology and what we usually get from the methodology. Because when we look, say for instance, when we look at the influenza surveillance for even 2009, when you had influenza A H1N1, we had from that method only 173 cases for the whole year. The percentage positivity over the last 5 years was about 8 for the highest particular virus, because we do a number of viruses, not just influenza. We do para-influenza like respiratory syncytial virus. And when we look at the positivity rate over a 5-year period, we have between 3% for a particular virus to 8%. The 8% was the influenza A/H1N1 in any given year. And the numbers are really in 100, 150 of all the tests that have been done, numbers-wise. So even though 7 sounds small, the method that we are using, it is still something not to take lightly, because it is probably indicating or a signal of what is happening in the community. Because for the most part, until we have many, many cases, community transmission is often silent. And that's why this method, even though we are getting what looks to be small numbers, it is of significance.
Yes, I accept that. But it is significant. But I'm just thinking that we've been with COVID now for over 2 months in Jamaica. And in a given week, it's 7 people who've presented in any public health facility with a respiratory problems who are positive. So I think it's significant. That to me is significant in terms of where we are in the scheme of things.
But Member Golding, if I may, remember that we have been advised that we have only tested, as only 45 of those cases that we have tested. So the reality is that until we get the numbers and until those other samples which have been collected from all the Sentinel sites have been tested, then we might not have a true picture.
Right. I think that's a fair assumption, Member Guy. So we will await the additional information which I've asked to be gathered.
But
right.
Minister, Chairman, in response to that though, just for clarity, is it not the case that all respiratory cases in these facilities, the public hospitals, etc., and some private, that all of them that present are tested? Is that not the protocol?
Yes, it is. But then there are categories of cases tested, which is what I think Dr. Webster-Carr was saying. If you get into contact tracing and identification of individuals that are linked to contact tracing of positive cases and so on, they may be in a separate category. So let her get.
Yeah, no, but I'm not focused on that. I just wanted to know whether it's the case then that of the persons who presented with respiratory problems to these facilities in Jamaica in that week, 7 of them were positive. Is that what we can derive from that? Or is it that there may be others that were positive that are not in that data who presented with respiratory illnesses in that week in those facilities?
Okay. So it's not only presentation, this is date of onset of symptoms. So the results that we will get probably over the next, or that we are reviewing, date of onset may go back further than week 16. So the numbers may change over time. But it's fair to say that what we are seeing is an increasing trend. And for this methodology, I need to say that we look at trends rather than absolute numbers.
Okay. Thank you. Member Guy, you have your hand up. And then if there are anyone else who wants to ask questions, otherwise I'm going to make some closing remarks on some new developments that I think would be.
Chairman, I have a whole series of questions.
Okay, let's go.
I think intimated that I would have.
Sure.
The first one, Minister, you announced yesterday, I think it was our Prime Minister, and sometimes it's difficult to say who is making the announcements, and you will understand. And pardon me if I offend you. What's our testing capacity now? I gather we got some assistance from the Koreans yesterday for the university laboratory.
So I'll tell you quickly, the University National Influenza Center, based on the 2 machines that were received yesterday, I am told could do 700 tests per day if they run multiple shifts. That machine processes samples every 6 hours. This is what Dr. Carl Bruce indicated at the launch. And then in addition to the machines that they currently have. So it could theoretically, and I say theoretically, because there's always a slip between the cup and the lip, depending on what is happening, the personnel available, and any glitches that they have. But theoretically, it could be over 1,000. And then for the national influenza, the public health lab, of course, we would have been on record of saying, again, theoretically, they could do over 1,000 if they run 3 8-hour shifts. So that would mean theoretically a couple thousand cases, or samples per day. Now that, to my mind, is practically unlikely, and unlikely for the reasons and maybe others. There are always issues around personnel and shift scheduling. There are reasons around samples and collection and delivery. There are reasons around glitches with the equipment. And so I really would just, it's important to say theoretical because it may not be the case more often than not. But certainly a lot more than what could be done before we got the 2 additions.
All right. Thank you, Minister. I want to ask a question because at the first meeting that we had on this committee, the Chief Medical Officer indicated that there were some samples taken from persons who were asymptomatic and during the contact tracing from the Bull Bay, and I might misquote by saying Portland, but just say from the Bull Bay, which have been kept. I'd like to know how many samples are now awaiting testing based on that, those that have been kept for a long time and those that we currently have awaiting testing.
You have any idea on that, Dr. Webster? All right, so those are very specific requests.
Yeah. Okay. All right, Minister,
take a note of that.
How many healthcare workers have been tested positive so far since our last meeting? In total, so far, and since our last meeting.
PS, you want to respond to that? I know we've had some more positives, but I don't recall how many it were at the last meeting. I think it may have been 6 or 7 at the last meeting.
Okay, can I get a definition of healthcare worker?
A healthcare worker, of everybody who works in the hospital.
Everybody who works in the hospital.
And
okay.
and you will recall, and I thought a little curious, but I'll add them to the list. COVID response team as well. Yes.
Yeah, I mean, there's no. It's not. I don't think we should be splitting hairs on it.
No, but I mean,
no, I'm not splitting. I'm not splitting ears. I just want to make sure that I'm giving the correct number.
Right. I'm actually on this rare occasion siding with you, member guy. So no need to.
Strange, but I'm comforted by that.
No. I'm not trying to split ears at all. I'm just trying to make sure that I give you the correct number. Right. All right. So I don't know if Dr. Webster, you have that number?
No, I don't have it, but there is a definition for healthcare workers. Anybody who works in a facility that has COVID positive cases, no matter what your position is.
Right,
So,
which is everybody.
which is everybody who work at a facility that manage COVID cases.
Right.
Okay, so
What's your last
I have
number?
to find-
Yes.
the number has changed since our last conversation, and I don't have the final number. Just to go ahead, Dr. Sakar.
So I have on my list 5 healthcare workers overall. These are persons who work at healthcare facilities that manage COVID. So if we're using that definition, there are 5.
Right, but I don't think that's a definition that is being used.
Five if they manage COVID, but I suspect that if you include the response team, you would add some more to that. I'm sure it's more than that.
So as we announced last meeting, there were 7 cases that were identified directly in the Ministry of Health and Wellness, and we are processing samples. We did a significant sample taking exercise over the last week, where we sampled over 350 of approximately 350 staff members from all of the buildings that we have, and we're awaiting those results. So that's why I didn't want to give you a number right now, and then the number is not the correct number.
Thank you, Pierce. Minister, which takes me back to my other question now. Why are we having delays in doing these tests for the samplings that have been done? And I say that against the background of people reporting, even whether it is so or not, but something reached the media the other night and the country that hospital staff was awaiting tests that was done 7-8 days ago and no result.
Right.
It's not confined to that particular hospital, Minister. There are other reports coming from other hospitals that there is a delay in getting back the results. Now, our capacity to increase our testing has been increased within the past 10 to 14 days.
No,
and all right, say give it a week then. Okay, last week Tuesday. Sorry, 8 days.
Right.
Why is it therefore
That's a big difference.
that yes, it does make a big difference too, but 8 days is sufficient time. If we can process the testing in 12 hours, 24 for confirmation, if this machinery at National Public Health Laboratory can give us 380 samples per 8-hour shift, and let's work with that 8-hour shift for now. Why is it that so many samples are taking a significantly long time to reach back? Because you know, Minister, it is important. If you test someone, whether they're with symptoms or not, the whole psychological aspect of waiting for a result does more harm to the individual than if they were not tested, because having been tested, they figure, say, hey, something is wrong here. Why are these guys testing me, right? Now, the trauma of having to wait for that particular period of time. Plus, when you think about the fact, if that news report is to be believed, then we have a challenge, because hospitals then awaiting results of possible positive cases will be less inclined for their workers to want to be there working and to accept other cases if they don't. The unknown, Minister, is what I'm talking about. And if we have the ability to reduce that time period, then certainly I think we should act on that.
Thank you, member. So I agree with you. There's nothing there to dispute that we need to make the test turnaround time efficient and as quickly as possible. I would say, however, that the problem existed 8 days ago, but since that time, with the addition of the machine at the public health lab, and of course, last evening with the new addition, which clearly would take a little time, we have been able to clear substantially, and I believe if not totally, the backlog. and we should see a lot more efficient turnaround from here on in. And the PS or Dr. Simone Spence, Dr. Spence, can you come in on that just to confirm if I'm saying what is?
That is also my understanding, Minister. The processing of samples is a little more complicated. So even though we talk about the 3+ hour process in terms of samples on the machine, there is a whole pre-screening and pre-process that needs to take place, which based on how the samples are received at the lab, there were some concerns and issues in terms of how they were being received from the field. So that in and of itself posed a little delay and challenge as well, which I know has been addressed. And so we should really see a significant improvement in terms of getting back the results in a more timely fashion.
Thank you. All right, I want to wrap up. Except that I see Dr. Oh, you're not finished? Okay.
Yes. To what extent has the St. Catherine and the work-based cluster affected the plans of the ministry to have the deployment of the mobile teams, particularly in the areas that you indicated some time ago, which were going to be done, the Western Regional Health Authority and the Northeast Regional Health Authority? Have these teams been active in those areas? And I'm particularly concerned about that Portland cluster because there seemed to have been a shift of focus, and unwittingly, if we have not done that Portland one, we may run the risk of having a blow up in Portland, similarly as we have had in the St. Catherine area. Have we done what was indicated that 2 weeks ago, last meeting, that we would have had this particular deployment of the teams in those areas?
Okay, I'm just asking the Dr. Webster to tell me what the numbers are to see if it cooperates with your assertion that we may have a blow up. It's a function of the trends.
So we
What's the numbers there now?
7 in Portland.
7 over what period of time? Overall?
Overall.
All right, so we have 7 positives overall. When did you have the last case in Portland?
Over a week.
Over a week. So I mean, remember, I appreciate the question.
No. Earlier on, Dr. Webster said that the positives that we are seeing now would have been a consequence of those persons who would have been contracted the illness 2 weeks ago, 14 days ago, and would be seeing the results now. So if the last test positive was a week ago, then certainly we would expect that there should have been. So the question has not been answered. Have we sent the team into Portland, the mobile teams, to do more testing as a result of those 7 that have been over a period of time? Because we won't know unless we do.
Right.
Okay.
So can I just
respond, member guy? I wasn't finished answering, but I'll just yield to her and let her respond.
So while it's not the mobile team, the Portland Health Department, assisted by the Northeast Region, has been on the ground doing their community fever or respiratory surveillance. So they are on the ground, and daily they are on the ground. We get a report every day from Portland as to what they have been doing in the community, because we have always stressed, because Portland, I believe, was the first place that got a influenza-like illness positive. And so they have been on the ground since then, doing on a cycle the community surveillance.
But just
do we have any results of how many persons from that intervention have been tested or sampled?
I don't have it right now. If I can find it in the next few seconds, I'll tell you.
And why don't you minister this one to you?
Well, she looked, member guy, just to say that we have had to pull resources from other areas into St. Catherine, St. Thomas, for example. So the Sarah team, the regional team, has had to really focus heavily on St. Catherine and also on KSA because of the numbers of cases. So yes, we have had to do that in order to focus where the risk is greatest. But it's always a function of risk assessment.
All right.
Yes.
There was a report last evening that one of the deportees tested positive. And I know I'm going to be given an answer, but I just want to ask a question. We were assured that those who were coming in to have been deported and coming in would have been tested before they arrived here. Have we placed reliance on those assurances?
Well, let's look at it this way. The protocols that governs the controlled entry that we have now started requires, no matter where persons come from, that there is quarantine arrangements that take effect, and that testing also takes effect. What it therefore does, it assumes that the virus acts in a particular way where even persons are tested in other jurisdictions, it could be at a point where the virus is not yet shown, and therefore we act in protection of our population to do tests on our own once the persons get here, the individuals. So that's what we did, and clearly worked out in our interest, in that all have been tested, by the way, and only one positive. And it could easily have been that that person may have been tested before, but tested at a point where the virus did not show, but was still present in the body of the individual.
Thanks for the answer, Minister. But you know, you have answered the question, but I can work with that. Because I don't want you to it's like a similar one earlier on, but we'll leave it right there.
No, I'm trying to give you the best answer possible, and I've taken that.
I know you work with certain constraints too.
No,
and final question.
Anyway, are you finished with your questions?
No, man, that's the final one now.
Okay.
The final question now. Minister, well, it's more a comment than a question, because there are concerns in the hospital, and I would personally ask, Minister, that you appoint a team to do a personal, by that team, of physical inspection of all your facilities without notice, to see whether your workers are having, frontline workers, your hospital staff are having personal protective equipment and being utilized. We spoke about the supply chain management already within the ministry to ensure that that is there, but there are still concerns coming out of the respective hospitals that, yes, it is said, but it is not here. So it is a recommendation. If it is accepted, I'd be greatly, I would feel good for all the frontline workers to make sure that there is not, as you said, a slip between the cup and the lip in terms of what happens in the sector. Because if we can have that independent audit done, then certainly we would not have some of the concerns and challenges that we have been hearing left, right, and center, or the grumblings that we've been hearing left, right, and center from the frontline and medical staff. So if that could be done, Minister, it might cost you a little more to do the audit, but do it. It will certainly cause a lot more people to sleep better.
Thank you, Member. Just to say that unfortunately, I can't, your assumptions may be a little off, and I know it's based on your experiences. My experience is that we have constant dialogue with the medical associations, the groups. We get feedback on an ongoing basis. I have a weekly meeting as part of my advisory group that includes the incoming and the present head of the MHA, right? MHA? Of the MHA, and they represent clearly the interests of their members. And whenever we get concerns expressed, we move in immediately and try to address those concerns. So I take the point that sometimes it's good to see without notice, And I do that from time to time with my pop-ups. Or if I turn up, I try to get questions answered or allow myself to.
I don't necessarily mean you, it's a team. A team
Right,
that does.
I understand. What I'm saying is that I don't know that we have such a big issue as it relates to shortages, but to the extent that there is, we are very responsive to dealing with it. And I'd certainly invite you, if you have any information, to share it with us, because we care about ensuring that our frontline staff are properly equipped. They can't do their work unless they're properly equipped. So I'm a big believer in that, just as you are. And we will do whatever is necessary to ensure that that takes place. Thank you very much, Member. Member Brown Burke, you have.
Two very quick questions, Chairman. The first thing is, we spoke earlier about 3,262 samples tested. Does that equate to 3,262 individuals who have been tested?
Yes. It does not include the repeat tests, as far as I understand.
Okay, fine. So that's one, and thanks. The second one now really just has to do with other workplaces that would have similar conditions as the workplace cluster that we have, and whether or not we have been reviewing our protocols and looking at that. I just want to make sure that, and I know that the public health department is stressed and stretched, but I also want to make sure that we are also learning from this workplace cluster so we can avoid it elsewhere. And I'm not sure if I've heard anywhere that we are doing anything different.
Your question is important. The second question, it leads me, if I may, into the final comment as to where we're headed and the role of this committee in that regard. So if members would permit me just to, in answering your question, speak more broadly at where we are. First of all, I do take note that the leader of the opposition, in keeping with his mandate, which we fully appreciate, had outlined some suggestions related to the work of the COVID response and called for an oversight body to sort of help to coordinate and to assess what is happening. In my mind, and I take the suggestion, but in my mind, the work of this special select committee of Parliament would or should equate to some sort of oversight, important oversight, constitutionally grounded, to providing such a sort of transparency, accountability, suggestions as to how we can proceed to maximize the response and to get the critical leaders at the level of the parliamentary leaders and others we call in as experts to manage this process. So I just want to say that that's my interpretation of a critical role for this committee, which is why the government, appointed this committee early in the day. And I think we have been doing a good job. And I think that all who have been a part of this committee on both sides of the aisle have come to the table with sincerity and with a commitment to overcoming this challenge. So I just want to state that for the record. Secondly, the future of the response to COVID, and you would have heard the Honorable Prime Minister speak to this and others in his press briefings, including last evening. At some point, we are going to move through phases. We're at a particular phase now, the community transmission phase. We see evidence of community spread. At some point, we have to now manage the normalization of our economy and society in a manner that is grounded in the public health response, given that this is a public health threat and risk. And some decisions have to be taken to ensure that those public health interests are maintained while getting back to life as we know it, in terms of work, in terms of movement, and I could go on. The next week or so, therefore, the committee will be exposed to a plan of sorts for suggestions, for comments around how we control or manage COVID-19 over the medium term, I would say up to a year, assessing as we go along in a manner that would address the public health concerns, but also attempt to normalize the country so that we can get back to work, get back to play, get back to all the things that we consider a part of our everyday life and living. You would have heard the Minister of Finance outline his plans for the economic side of things. The same is happening as it relates to local government and community development, labor, other areas of economic activity. And of course, for public health, we have to be right and center of that. The Prime Minister has appointed a multi-sectorial committee that will deliberate, help to guide that process. I just want to signal to this committee that we intend to take a plan, firstly to the Prime Minister and the Cabinet, then to this committee that will seek to manage that process in a way that public health remains center and focus in the best interest of the population. So issues around vulnerable communities, vulnerable individuals, border protection and control in terms of entry with the CR airports, those are issues that we are developing protocols around, and that will guide us in the next phase. And I just want to say to the committee, your input on this once we sign off on an initial proposal will be quite useful in terms of how we intend to address the future. All right, so I wanted to just signal that. I see 3 hands up. I think Member Brownberg had asked her question already. So, and I believe Member Guy. So
I haven't heard that response, Minister, but I'm going to allow you to get away with it today.
Minister, I have something to say. And I won't allow you to get away with it.
Go ahead, Member Guy, and then I'll go to Member.
Your characterization of what the leader of the opposition said is at fault.
Okay.
Because what he was referring to was and in his comments, he alluded to a epoch type oversight of the country as it relates to COVID and not necessarily the health component of it. He was referring to the whole country approach, economics, the social, everything. We are here looking at primarily the health aspect and how it interrelates with others. His comments were directed at just like in the IMF program, we had the epoch, he was looking at something in that vein. So I don't think he certainly was not referring to the fact that we need not have our committee. He was looking at a recommendation to government.
Right. So would that be the one that was announced yesterday by the Prime Minister?
It was something of the same ilk, as far as I understand.
No, it would not be, because the opposition is not on that committee. That is not a broad-based committee. That's an exclusive committee that excludes the opposition.
Okay. Well, the opposition is certainly here at this level, and there is ample leeway to express the issues and the concerns. But I'll raise that as a member of the cabinet with the Prime Minister and the cabinet. But just to say that this committee is, I think, quite useful and does provide the opportunity for voicing all the possible concerns, and we will take those suggestions on board as we have been so far. But thank you, Member Guy. Member Golden, you had another question. Your hand is up, and they would like.
Yeah. Thank you, Minister. And I would endorse that this committee is useful, and the fact that it is being done through a parliamentary process is also a good example of how these things ought to work. But the remit of this committee is not as broad as the overall strategic planning for delivering Jamaica from the effects of COVID, which are, as the public health side of it resolves itself, the economic and social sides are going to be exaggerated and already are. And so I think that is what Dr. Phillips was speaking to. And the question of whether what was announced by the Minister of Finance yesterday meets that is a point in issue. But the question I had for you, though, Minister, is this. I'm glad to hear that you'll be coming with some initial proposals for how the public health side of it will be dealt with going forward, given the need to get the economy restarted, because the social impacts of the effect, the contraction of the economy and the response to social distancing is severe. So we do need to, and I think everybody recognizes this, need to have a balanced approach. What I would say is that we need to bring forward, the question of how we're going to deal with the vulnerable people. We need to bring forward that, because this is something which I've been speaking to in this committee for several weeks now, that there needs to be a policy for focusing on how, from a public health perspective, we minimize and protect the risk to protect the vulnerable population, the elderly, and those with pre-existing conditions that would mean they have a higher risk of serious illness if they get the virus, and have a comprehensive strategy for that and implement it soon, vis-a-vis the rest of the population who, like the workplace cluster, will get this thing and 80% are asymptomatic. In other words, as you have said, this virus is not going away. We're going to have to learn to manage our lives and manage our society so it can function with it around. And thank God, for most people, it is not even a serious illness that they will get. It will be a very manageable situation. On the other hand, for a relatively small number of people, percentage-wise, it is a serious risk, and we have to protect them. So I'm looking forward to seeing those proposals soon, and so that they can be actualized, because I think this is taking too long.
Member, I would agree with you, except when I would depart from your views where you say it's taking too long, and I'll tell you why. This virus has operated in phases everywhere around the world, even with its short history. And we did rationalize and explain, we thought anyway, very clearly why the phases were important. First being preventing the virus, or prolonging or delaying the virus entering the population through border management. The next is containing once it touches down through contact tracing and quarantining and isolation. But we fully and always recognize that this is not a virus in an open society and a globalized world that you're going to keep out permanently, or you're going to avoid having as a normal course of life. But the public health system, until the virus became present, was never able in any jurisdiction to cater for an avalanche. So we had to manage the process. We have, I think, managed the process, and I again pay tribute to the public health workers who have been able to do very well through the contact tracing to control the spread, while, very importantly, we prepare the public health system to deal with those who require hospital care. I think we are now at the phase where the team who have been working on this for some time are able now to say, these are the new arrangements to accommodate the next phase. And we could not have pushed those arrangements in the earlier stages. But one, it would take some time. Thirdly, we have to prepare the infrastructure. And these are not things that you can do overnight. Under the circumstances, given the limitations in public health, I take no credit except to say I work with a team that have done exceptionally well. And I appreciate the fact that this committee has recognized that and continue to encourage the effort. So when we unveil, or at least discuss, I'm anticipating the comments of members, but I wouldn't want to give an impression that they are somehow underperforming in terms of the preparation of the next phase, because I think, frankly speaking, it had to happen this way, and they're making good progress. Can I ask Member Malahoo Ford to just come in now, please?
Thank you, Chairman. Just seeking clarity on two matters. Member Guy had indicated that the opposition is seeking an epoch type committee in place to oversee the government's response to the crisis. Did I get that correctly?
Yes.
That is
That was part of the recommendation that was made. It was alluding to something like what we had for EPOC.
All right. And secondly, in respect of Member Golden's concern about the protocols for dealing with the vulnerable, I wonder if Member Golden probably could help the work along by, looking at any recommendation of what the government would be responsible for and what people who fall in this vulnerable category would be responsible for, because managing lifestyle is a difficult matter, and I don't know that it is for the government, however necessary a work that has to be done to manage the lifestyle of persons who put them at risk. So in this critical area, I think this is probably where most of the work will have to be done. How do we sort out what government realistically is responsible for and should do, and what part of the work must the people take responsibility for? Thirdly, I said two, but thirdly, is it the recommendation, Member Guy, that the government, the committee that is being constructed now, that a member of the opposition be on it? I wasn't so sure what the complaint was, that currently there is no one from the opposition. Which committee was that referring to?
And there's a lot of, someone has their mic on. Could you just turn the mic off, please? Somebody, Gain Morrison, whoever that is. Yes, you can go ahead.
Thank you. I'm going to reply and then ask Member Golding to finish it. What I was basically saying is that the recommendation came from the leader of the opposition that we should have a whole country approach to the management of the consequences of COVID on the country. And
Can I just ask you to pause? Does that recommendation today take into account what the Prime Minister had announced yesterday at the press conference?
With the exception that the Minister said that, the Chairman said that that's a similar a committee, and Member Golding responded by saying there's no member of the opposition on that proposed.
I see. So save for membership from the opposition, and I believe the Prime Minister did allude to the incompletion of the committee at that point. Is that the idea of the whole of government that you're looking for?
I cannot speak to the entire composition of it. I would have to research a particular matter, because quite honestly, I didn't listen to the entire speech of the Prime Minister last night. But I don't know if Mark did and would care to comment on it.
But just to say, what Prime Minister had in fact signaled was the assembling of a team which would look at the issue across all of government and not just from a health or economy perspective, but all of government.
And we are on the same page with that.
Right. Okay. I just was saying that is already part of the consideration of the government going forward.
Is that the committee that the Minister of Finance spoke to and is reported in the Gleaner as having given names and so on of who the memberships is?
I think there were two announcements, if my recollection is correct. But I think Prime Minister will clarify. But if the recommendation relates to the assembling of an all of government team, I mean a team across all of government, not just economy, not just health, but to look at what is required, just to clarify that is being done.
Yeah, I mean, I think there's a danger of having too many different committees and groups looking at broad questions. I think it needs to be structured in a coherent way, but it needs to be, I think there needs to be the appropriate stakeholder representation from all key elements that would enable that committee to be properly represented or representative of the different interests who need to be taken into account. Is there anybody, for example, representing persons with disabilities on that committee?
I wouldn't say that it is an error in approach, Member Golding. I mean, different people may conceive of a different way of doing something, but certainly the work has to be done at different levels and in specialized areas, and then that would be fed up to a broader committee, as it were, for want of a better word. But even where the committee is broad-based, the work still has to be broken down, because technical expert matters will have to come in relation to different areas, and that can't be generalized, I'm afraid. I mean, we can't give public health work to non-public health experts, for example. You can't give technical, fiscal, and monetary matters to non-experts or people who do not, and the same would go across any area. But the bigger point is taken. I'm just saying, take into account that the government has made the announcement.
Yeah, but AG, the committee that Minister Clark is reported as having announced is a broad-based committee. You know, it includes several people from the private sector, people from the Jamaica Agricultural Society, there's a trade unionist on it, and so on. I'm assuming that is the broad-based committee. But I'm saying that there are some important stakeholders who are not included. That's all I'm saying.
Got you. Let me just answer it this way. To the extent that the opposition has raised a concern or has put forward the suggestion of all of government, all of society approach, that has already been considered by the government and is being constituted. I think that is the simple point. And it is my understanding that the parliamentary opposition will be properly represented in that forum.
Because we were not included in the long list of names that was published today.
But it is my understanding that when that all of government, all of society team is finalized, the parliamentary opposition will properly be represented.
Okay, thank you very much. On that note, I would like to ask if there's any other business so we can close that.
Mr. Chairman, just because AG made a comment, I know that Member Gordon has not responded as it relates to the suggestions, taking up the challenge of putting some suggestions on the table about what government will be responsible for amongst the vulnerable group. But I don't think, just to ensure that there is no misunderstanding, I always get a little nervous when policymakers begin to say that among a group of individuals, what needs change is their lifestyle, and that government can't take responsibility for that. Because when we begin to say that, sometimes you get the impression that we are ignoring the realities that people live that determine their ability to respond to some things. And I just wanted to place that on a record. COVID is in fact showing up a lot of inequalities in our society, and that is one of the lessons that I'm hoping we do not miss.
Chairman,
if I could just add to that, because the question was asked of me and I hadn't really had a chance to respond to it by the AG as to what I had in mind. For example, there are elderly persons who live in conditions where they are not socially distancing. They cannot effectively be separated from the rest of the population because of their living circumstances. They live in congested yards, for example. An opportunity must be provided for those persons to be moved into an environment where they're less exposed to the risk of infection. That's what I'm talking about. If you're saying who would pay for that?
No, I understand. I was just asking a little flesh out. And just to clarify through you, Chairman, that the concerns are real. And to say that I am asking for a separating out of what government is responsible for. This is in no way indicative or suggestive of any insensitivities. You are right, and I do share the concern. But also, I personally find that when we step in and do the work that the people should properly do for themselves, the problem never gets resolved. And year in, year out, we've had existing problems. And leadership has stepped in and relieved people of their share of the responsibility instead of properly enabling them. That is the kind of distinction I'm talking about. Because if a particular behavior or habit results in a problem, among other things, and more critically, it is a change in that habit or behavior that will yield a solution. So I mean, government will have to do its part in including looking at the wider context, issues like ensuring that there is reliable supply of water, looking on housing conditions. But I don't know, I mean, we have to, if we're going forward in a real way, because you're right, Member Berg, this has highlighted some of the harshest realities of the society. Many of them we have been aware of, but for some reason it was convenient to amble along and turn a blind eye to them. But when a matter of life and death stares us in the face, it's an existential threat. We cannot ignore it any further. And part of the work that leadership is required to do is to help enable people to do their part. That's the point I'm really making.
Just to remind members that I take the point raised by the three members in terms of the approach and the concerns. Just to say, however, specifically that we are developing a program to ring fence vulnerable groups. We have started, in fact. You spoke earlier about the infirmaries and and I indicated that Minister Mackenzie has been doing some work related to that group. We discussed the other care centers, golden age homes. We have done some things in terms of the hospitals, which is why we divested or are divesting the hypertensive and diabetic patients, some 75,000, to private practitioners as part of the managing the crowding effect and the likely risks that it would pose to them. Some of the other things will come, as I had indicated in my outline of the next phase, that would include further measures. So while the issue around managing personal responsibility and so on is important and is captured in some of the public education programs, we do recognize that there are vulnerable groups too that require assistance, and the government is by no means shirking its responsibility or avoiding its responsibility to respond. And there are specific programs that are going to be targeting those groups.
Minister, all right? if I may, I know you're wrapping up, but I just wanted to make sure that I make the point that even now, while we're developing the different programs to deal with at-risk and vulnerable populations for COVID-19, we have employed the strategy in terms of risk management in dealing with Alarica cases. The assessment that was done on the households, and some of the characteristics that we did look for is household density and also the risk profile in terms of the type of persons that lived in the households that the persons who were positive were in. And it determined which of the persons we had to put into isolation facilities. So even as we further build out the strategy, we have been employing the strategy in terms of what we have been doing for the Alarica situation.
Okay, I'm going to move to any other business now. Any other business? Any other business? Once, twice? No? All right, great. So members, let me just close by thanking all of you for attending, our regular members, but also our specially invited guests, the Permanent Secretary, Dr. Simone Spence and Dr. Webster Carr. I enjoy chairing these meetings because I think it is useful to me as minister in terms of the ideas that are shared and the suggestions made, and useful, I think, also in terms of the knowledge that is imparted around the program, the strategy, and the cooperation of the opposition. And I want to just place on record my appreciation to members of the opposition who are part of this committee, Member Guy and others, who I believe have been extremely cooperative in terms of the approach, and on my side, to the members of the government benches who similarly so have been cooperative. So I think we're really doing what is in the best interest of the country. And I just want to cite that and thank that. Thanks to the parliamentary team, just to ask them to note that the concerns raised around the recording of the minutes, I think Member Golden raised a few issues, minutes coming across as being draft minutes. If there are any issues around clarification, feel free to contact my office or the individual members so that those corrections can be made. Just to say too that I will follow up on the persons with disabilities and Minister Clark. The NWC as it relates to water and low scheduling. I think there's an issue around, well, that's not an issue anymore, the issue of ventilators. And I will follow up on the nursing homes as requested by the member Guy in terms of the protocols. I'd ask the PS to just make a note of that and do some follow-up. So we'll try and address those in the next meeting. Thank you very much.
Chairman, just before you go.
1 second. Yes, Member Guy, and then Member Malawford.
I lead the lady, Chairman.
Oh, lovely.
Thank you, Member Guy. Just saying that it may be useful, Chairman, going forward for us to collate a set of recommendations coming out. So primarily, the committee has been receiving information from the ministry, very useful information, and we've been interrogating the information, but perhaps we could consider looking specifically at a menu of recommendation. And you could go back, Chairman, to the cabinet to see where those are filtered, separate and apart from the report to Parliament, which would be required as a matter of course.
Thank you, Member. I normally do, but not in a formal way, as you are suggesting, but that could be useful also for the record. So I'm going to ask my team and the parliamentary recording secretary to just pull out the specific recommendations so we can make it a formalized place for the records. But I normally do raise those internally, which ultimately finds its way at the level of cabinet when we report once or twice a week. But thanks for that suggestion, useful. Member Guy, your final comment?
I was just trying to ascertain whether the numbers of SARA and ILIs for the epidemiological week 17 numbers have been received yet, the total.
That Member Dr. Webster? No. I will follow up on that. Dr. Webster, please get that information to me, and I will pass it on informally to you, and then we can record it next week.
Thank you, Chairman.
Note, please. Member Golden, you have a final comment? Your hand is up.
Sorry, no, I'm fine, thank you.
Okay, thank you very much, members, and thanks to all the others and to those who are listening in technology land, including our journalists. Thank you very much. All the best. Keep safe.
Meeting, Chairman.
To me, I call up on the car, the suspension, the spring, the tire, down to the paint damage.
Lord Oliver, man, it wasn't so bad, man.
Listen, fear